This is Dr. Howard Rollins with EHR TV. I have the pleasure today of speaking with Teecie Cozad, who is a perioperative clinical consultant for Merge Healthcare. Teecie, thank you very much for being with us today.
My pleasure.
I have a few questions for you. Now, my understanding is that AIMS is really kind of at its early stages of adoption, even though it's been around for a while. Do you think that's true, and if so, why?
I do think that's true. I think the primary reasons are that there are several. One, when an AIMS is purchased, it's purchased by the hospital, but most of the AIMS practitioners, the anesthesiologists and CRNAs and residents, the anesthesiologists are part of a private group, so they're typically contracted with the hospital. So you have a set of users who are not hospital employees, but the hospital is purchasing the system. That's probably one of the primary ones. The second reason is that anesthesiologists have been hesitant to move forward with an electronic record for reasons of fear of medical liability. They're afraid that it will put things in a record that aren't necessarily reflective of the case, and they don't want it to slow them down or to take their attention away from the patient.
Give me a few examples of why having an AIMS improves safety in the operating room.
In our system, we have several methods that it does that. Number one, we have a method of capturing the patient's medical history from them via the web and pass that information on to the anesthesia preoperative record as well as to the nursing record.
How was that information put into the system to begin with? Was that from the patient?
From the patient.
Where do they do
from
that?
Home or even a surgeon's office as soon as
So
they
there's a
hear
patient portal.
There is a patient portal. The nice thing about our particular patient portal is it also helps to triage patients preoperatively and smooth out throughput. But back to the safety issue.
Right.
Joint Commission found that the number one reason that anesthetic accidents did occur was lack of communication about the patient. So that's number one, being able to communicate that information.
The various people that are involved in the care.
That's exactly right. Second thing is we have a nice, robust rules engine underlying our application, which means we can set up some prompts for the clinician based on what they wish to be prompted on. One of the major ways of preventing a surgical site infection, for example, is for the patient to receive an antibiotic within 60 minutes of incision. We have a method of prompting them to do that if the system hasn't seen an antibiotic, so we'll recognize what types of drugs have been given and prompt them, but only for the cases that it's important on. If it's a cataract patient, we won't prompt them, so it's smart.
And this
Same
can
thing
all
for
be
beta block.
set up by the user.
It's set up during implementation, those
Right.
rules engines, and then can be tweaked along the way as things change, or, you know, we allow documentation of safe IV catheter insertion for central lines, beta blocker delivery.
So you're hitting on skip protocols, and it's clear to me, at least, I believe this will help with compliance with skip protocols.
Absolutely. If a patient's temperature drops below the agreed upon level that the institution wants to look at, we can remind them to put in a note about how they're keeping the patient warm as well.
For me, certain items are often overlooked as being just run-of-the-mill. You do it so you don't think about it a lot. But I'm always concerned about correct patient identification. I think that's a very big issue because that's one of the most avoidable and disastrous complications that I can think of.
Absolutely.
Tell me how your system deals with correct patient identification.
We've incorporated barcoding capability throughout the system in many ways, not only for drug delivery and scanning in advance of delivery for safety reasons, but also from the patient identification point of view. We can make sure that we are working on and selecting the correct patient by barcoding their wristband in advance of starting the case. And that is one method to be able to assure positive patient
So would that
identification.
wristband be put on when the patient enters the hospital by the admitting department?
By the admitting department, and we recognize the hospital's barcodes for account number and that sort of thing. We also have a method of making sure that the anesthesiologist documents his or her participation in the timeout. So that's also very configurable based on the institution's methodologies for documenting that. But
And
that's the other
does the
major
system
one.
recognize different users during the same case, say during lunch breaks? Or I certainly, as an anesthesiologist, would not want to have something attributed to me that I didn't do.
Sure. We also use barcode scanning as our primary method, although we do other methods as well, including magnetic stripe cards, etc. But use a barcode for swiping into the system saying you are here and what your role is.
Right.
So when you are relieved for lunch, the relieving physician or clinician comes in and also swipes in and takes over care, and immediately within the notes of the system,
They are now responsible.
it's documented as medical responsibility is shifted to the new person.
How about concurrency issues? How is that dealt with?
We deal with them in real time. During that scan-in, the system looks for other cases that would conflict with the concurrency levels that are set by the institution. In New York State, for example, it's a 3-to-1 ratio, physician to CRNA or AA. In other states, it may be 4-to-1. So what the system does is it looks at the time of sign-in at all concurrent cases, whether they're open, closed, on sign-in, and on editing. Because sometimes you say, oh, this case started 5 minutes before I was able to, look at it and sign in or what have you.
So it will let you know, and then you can override if you need to.
You can override if you need to, but it also will show you where the open cases are, where the issues are, so that you can use your other methods of communication to communicate with somebody and say, could you please close the record in the PACU or attach your sign-out time. Right.
So now, if you had to sit here with me and tell me a few things that make Merge Ames unique and better, if you will, than anybody else's Ames, what would you say are the really big ones?
The very largest are the intuitive user interface. It's very easy to use, and it's all one-touch documentation to a large extent, which means if I'm providing anesthesia, I don't turn my attention away from the patient.
Right.
I also chart when it's time for me to chart from a patient care point of view. The system is designed to, by tort, you can't document at the same time you're delivering care.
Right.
So our system is designed when you have time to do that documentation, to go back and document at the time things happened.
Well, along those lines, has your implementations been fairly smooth?
Very smooth. We
How
have
long
a
do they take?
they are 5 months. There are 8 events that occur, and they usually go off without a hitch.
And your users are all the ones that you've gone live with, they're still live?
Yes, we have our very first customer. Our initial beta site customer is still live with our system. So, and that's 12 years ago.
How do you support implementation?
We have implementation teams which include project managers, application specialists, hardware specialists, and engineers for interfacing, who go on site for meetings, setting up and configuring the system. And that configuration is a big plus for our system.
I'm really happy that you mentioned the word interfacing, because it's so important, and I know that it's not to be taken for granted.
It definitely is
a real challenge, isn't it?
It is a real challenge. There are many interfaces that many companies do fairly easily along with hospitals, including the standard ADT scheduling, surgical scheduling, lab interfaces, outbound records to document control, that sort of thing. Those are easy. The difficult ones are clinical integration, and I must say we have a very nice track record for being able to exchange clinical data, like the patient's history and things like that, with multiple EMR systems.
So if a hospital is not a Merge hospital, does it mean that they can still have a Merge Ames?
Yes, very definitely. In fact, the Merge Ames is meant to coexist and live with other hospital legacy systems. The interesting part from an anesthesiology point of view is that as part of a huge EMR, anesthesiologists don't always get an AIMS system that works the way they work.
Right.
As a product that started simply focused on anesthesia and its documentation and drug management and the things that are peculiar to the practice of anesthesia, we'll put our system up there with any in terms of working the way the anesthesiology provider works. And we have had from the beginning needed to work with other systems. So,
as somebody that knows as much as you do about AIMS, do you recommend that a hospital includes the anesthesiologist in the decision-making process?
absolutely.
Do you see that that's happening?
Not always. Often that decision is made in the highest levels of the hospital with, the CIO as
Right.
one of the primary decision makers. And they should be leading that discussion and making sure that the interfaces are legitimate and that sort of thing. But the anesthesiologist, chief, or the person who's really charged with making things operational within the department really need to be included in that decision. And I encourage every anesthesia department head to ask questions in advance, do as much research as they can into what's available on the market.
Right.
Our best customer is an educated customer.
One thing that really intrigues me is this barcode application. Are there any where else will that come in handy during my case?
Sure, besides the patient ID and identification of the clinician who's working in the case, we also have a drug management system, which is expansive or not expansive, depending on how you want it implemented.
So what's the most I can do?
So
with
the
it?
most you can do is we can provide a mechanism for pharmacy and anesthesia providers to get together and share information, and we can provide scanning in advance of drug delivery, which is a safety mechanism that hospitals are implementing in other parts of the hospital throughout the hospital. There hasn't been really a successful way for that to happen in anesthesia because they really are one of the few places left in the practice of medicine where you create the order, dispense the drug to yourself, prepare it in a syringe, and deliver it to a patient with no other set of controls on that process.
No nurses and no orders.
Right, no orders really. So we have a great medication management system which optimizes that for the practice of anesthesia and allows pharmacy to keep track of things like narcotics and what have you. So we do not only charge capture but complete narcotic reconciliation within our system if the hospital wishes to implement that. We also have a drug cart that goes along with our system, which in many instances, drug carts add steps to the practice and delivery of drugs in anesthesia. Ours is one with the AIMS, and there's no duplicate documentation required. It's a very nice method of controlling and delivering drugs.
Revenue capture for the professional fee. That's important to all anesthesiologists.
Yes,
we want to make sure we know that we're losing revenue because certain things are not being charged for, and the professional fee may be lower than it should be because the coding is incorrect, etc. How will this help me?
So we're the only system that I know of that actually incorporates a full, complete set of CPT codes and ICD-9 moving to ICD-10 codes into the system.
Are you ready for ICD-10?
Absolutely.
Okay.
And that's because we use a third party who provides us with up-to-date codes every quarter of the entire library of codes. We have user interfaces which allow very quick identification of the CPT code that's appropriate for the surgery, the surgical diagnosis. We automatically provide coding for skip compliance, for example, the category 2 codes, as well as those things like the additional CPT codes that anesthesiologists earn by putting in A-lines,
modifier,
all the some of the modifiers are automatic. The system recognizes those.
Like the age of the patient,
Yes.
or the ASA status.
And we have a great method for capturing discontinuous time for the times in pre-op holding where the blocks are delivered that will be the primary anesthetic during the case. So we really take care of all of that automatically and send those bills directly at the close of case over to the billing group and pre-populate the billing record with those, along with having available a copy of the anesthesia record. So on all accounts, from a provider point of view, professional fee capture has been shown to improve anywhere from 5 to 10% with implementation of our system, and days to bill drop down, at Hospital of the University of Pennsylvania, for example, down from 10 days to 1 day. That's on the professional fee side.
Right.
We also do some really nice revenue capture and cost savings capabilities for the hospital. Again, this goes back to the fact that it is the anesthesia provider who's the user of the system, often private practice group, and the hospital who's purchasing it. Unlike many EMRs, we actually have a real return on investment for hospitals. When you think about it, anesthesiologists are in a very nice position from a potential revenue position with the hospital.
How so?
They see, in a hospital who does any decent surgical volume, anywhere from 40 to 60% of inpatients.
Right.
They are actually assessing their health, naming current illnesses, and saying how those illnesses might affect their anesthesia plans, taking those into consideration. It happens. Patients coming in for a knee replacement. Everything about the knee replacement and that history regarding that is great in the chart, but someone has failed to mention that the patient has a history of atrial fib. So that's what anesthesiologists are great at. And as a result, they can positively impact the granularity with which patients' comorbid illnesses are documented. And we provide a fabulous way to help them do that even in the arcane terms that are used by medical records and CMS billing, et cetera. So we have shown a 4 to 6% increase in the hospital's case mix index just through our pre-op information capture and the ability to code that data.
That was an unbelievable answer, by the way.
I'm sorry about that.
It was great. You know this product well. Merge is very lucky to have you.
Thank you.
Now, I think we should take a look at the system.
Okay. First off, right off the bat, if I am a CRNA, for example, in a care team practice in a hospital, and I'm in the OR preparing the OR for the entrance of the patient, I may not have been the one who did the pre-op. So having the ability to review a patient's pre-op in advance of surgery with the touch of one button is great. This shows several things. It's the entire pre-op of the patient. Much of this information was gleaned from the patient portal, where they have provided their health history, and we're now sharing that with multiple providers. I have the anesthesiologist has done a physical exam. That's really the only thing they needed to add to this. Had this patient had a difficult airway during a previous case when the system was in use, it would highlight that and provide the difficult airway note right there for the provider so that they can see what was used for that airway in the past surgical procedure. But not only that, if we go to the input screen here, the first thing we typically start with is the ability to access previous records. Again, with one touch, I can look back over the patient's surgeries and see which records I want to see with a one-touch link.
And that is something that can delay a case an hour. If all of a sudden I find out outside the operating room I need to see the previous record, by the time I get it, get somebody to go to the admitting or to medical records
and find the old charts.
That's right. This is really an advantage.
And it's a great advantage of electronic systems. And the second thing is I am showing the first interface with the system, which is a real-time scheduling interface. And as cases are added on or subtracted, canceled for the day, they will be added or adjusted to the system right off the bat. So that's all great. As I start working, I can scan the patient's wristband and have it go just to this particular patient's record and eliminate all the others, and that's a method of positive patient ID, as we discussed earlier. And then
Let me
here we go.
interrupt for 1 minute. What would happen if you scanned the patient's wristband right there and it wasn't the patient that was supposed to be in that room at that time?
It doesn't matter. It's going to pull up the patient record who is in front of you and assign them to that room automatically.
Okay.
The computer is set up to be designated as a certain location, so
Okay.
it doesn't matter.
Okay, thank you.
So this is a touch screen, which is meant to give lots of room for touching. Everything that needs to be documented can wait until you're ready to document, because the first thing of importance is taking care of the patient. We come in and set up these buttons according to your workflow, and part of the robustness of the system is it knows what type of surgery or what type of anesthetic procedure you're going to undertake. So if it's a general anesthetic assigned to certain types of cases, this is the general anesthetic view. These buttons are one-touch links to everything that you need to document. We don't want you spending any time on the computer. We really want you to be able to focus on your patient.
If the procedure changes during the procedure, and you started with a very simple procedure and the template indicated that you were doing an appendectomy, but that turned into a hysterectomy and a
Sure.
major bowel case,
Then-
will it accommodate that?
Yes, it will. And you can change the layout with a click of the finger to any other type of layout that you have built into the system.
During the case?
During the case, on the fly. For example, if you want to see what's been going on with the patient on a more frequent vital signs capture basis, I can touch this 3-to-1 grid ratio and switch from every 15 minutes to every 3 minutes. Now I'm showing a lot of additional physiologic data that's been captured by the system.
That data is being captured whether you
Throughout.
display it or not.
That's correct. That's correct. And it's a variable amount of time that you wish to do that. I have various capabilities. When labs come in from the lab interface, I can light up this button that say, hey, you've got labs in. You might want to view those. And we can automatically chart these so that very quickly you've just, taken something that, people spend minutes on the phone trying to find out, are my labs ready? I'm waiting for whatever. So ease of use, we're starting at the top, working our way down, and by the time you get to the bottom here, you've documented an entire case of a general anesthetic. Again, the system is smart. If the patient had come in for something short, like a little tonsillectomy, the whole setup changes so that I can just very quickly document procedure start time, just that quick. One case note, yes, that's how it's going. And then I'm essentially, except for documenting my drugs, done with my documentation for that little short case. And for those drugs, I have various lists that I can access that really make it fast. We don't want you to have to scroll and be able to very quickly say what you've given. We color code by drug class with both our barcodes and our screens so that you can indicate what you've documented. So we don't want you to have to do much more than that in terms of documentation.
We talked a little before about skip protocol. Show me how that would work here.
So let me go back to my intra-op here, where the patient's going to require a antibiotic. I have just documented that I'm ready for induction. Only the system hasn't seen an antibiotic yet. So our method of alerting you to that fact is to give you the note that you need to document for that antibiotic delivery.
Okay.
And I haven't actually documented any drug delivery. I can mark things that are required to be filled out if I wish. And I can document that antibiotic. It's going to show me what drugs I've documented so far. And when I want to add a medication, I can either add a bolus or an infusion. In this case, we'll add an... Now, one of the capabilities of the system is to remind you that this patient has shown an allergic reaction to this. This patient their reaction was shortness of breath. You decide whether that's what you want to give or not. We also have the ability to accommodate intolerances instead,
But by hitting OK, I, as the anesthesiologist, I've acknowledged that I've seen that.
That you've seen that, and you know it. And you can give the drug based on what you guys want to do, or not. But in case you do, we'll go ahead and put this in. It is now not only going to appear in my note, but it's going to give the exact time here for delivery as up here on the record. And it's going to let me do some things here. So I've documented it both in a note for medical records so that they can do the hospital side of skip compliance, and in the drug grid as well. All of our notes are meant to be really documentation by exception. As long as everything is correct there, and 90% plus of the time it is, that's all you have to do. If you need to add a note, great. It's very simple. If I want to back time that because it happened actually a few minutes ago, I can do that. I can also select a timestamp so that I don't have to go back and see what time something was done. It will automatically match my times so that you don't even have to go back and edit those times.
So let's move on to the recovery room now. The case is over.
Yes.
And we're about to transfer the patient.
Right.
First of all, will people outside the operating room, such as PACU, know that the case is over? Is there a way to indicate that?
Yes, we do have an electronic whiteboard, which can be shown in the recovery room as well as in the OR locations near the where you typically will see a white erasable board.
Right.
And so we actually, as you document the case, induction finished, surgery started, surgery ending, etc., it changes the patient status automatically on the board. So in the PACU, they can see which patients are at emergence and soon to be coming in. And so that's a big heads up.
Okay. So the case is over. Take us through to the PACU. What happens? Does the chart continue?
The chart continues. We will suspend it here in the OR, and then in the PACU we will reopen.
I see.
And again, using buttons very quickly, document handoff to the nurse so that you can say, what's going on with the patient. We have a great perioperative summary report, which allows, it's a nice handoff report, and can be viewed on screen at the patient's bedside via a little tablet, touch tablet, etc. And this shows you the highlights, exactly what time the antibiotic was administered, so they know when to give the last dose for the patient. So those reporting mechanisms really are enhanced by an electronic system.
Seems to me like you've thought of everything.
Well, we've tried hard to think of everything, but we have great users who give us feedback. Our last version, we were able to get at 85% of our user feedback. And, until you use a system every day, it's hard to see how it can be improved. But, we have done, we've always listened to our customers, and that's been our greatest method of input for what we need to develop.
Sounds like a smart business plan. Well, thank you very much,
Thank you
Teecie.
so much.
I appreciate it. This is Dr. Howard Rollins. I'm here at the New York State Society of Anesthesiologists PGA meeting for 2011, and I've just been speaking with Teecie Cozad of Merge Healthcare.